Airway pressure release ventilation, or APRV, is a mode of ventilation that was first described in 1987. It uses a philosophy that differs fundamentally from that of conventional ventilation. Whereas conventional modes of ventilation begin the ventilatory cycle at a baseline pressure and elevate airway pressure to accomplish tidal ventilation, APRV commences at an elevated baseline pressure, similar to a plateau pressure, and follows with a deflation to accomplish tidal ventilation. In addition, during APRV, spontaneous breathing may occur at either the plateau pressure or deflation pressure levels. Airway pressure release ventilation has been described as continuous positive airway pressure, or CPAP, with regular, brief, intermittent releases in airway pressure. The release phase results in alveolar ventilation and removal of carbon dioxide. Airway pressure release ventilation, unlike CPAP, facilitates both oxygenation and CO2 clearance, and originally was described as an improved method of ventilatory support in the presence of an acute lung injury, or ALI, and inadequate CO2 ventilation. Airway pressure release ventilation is capable of either augmenting alveolar ventilation in the spontaneously breathing patient or accomplishing complete ventilation in the apneic patient. The CPAP level drives oxygenation, while the timed releases aid in CO2 clearance. Technically, APRV is a time-triggered, pressure-limited, time-cycled mode of mechanical ventilation. Other names known of the APRV are bilevel by Covidian, APRV by Draeger, bivent of Gettingy, or formerly Mackay, biphasic from Vaier, formerly known as CareFusion, or duopap under the Hamilton brand. APRV allows unrestricted spontaneous breathing throughout the entire ventilatory cycle. Advantages of APRV include significantly lower peak and plateau airway pressures for a given tidal volume, the ability to superimpose spontaneous breathing throughout the ventilatory cycle, decreased sedation and near elimination of neuromuscular blockade use. Features that distinguish APRV from other modes of mechanical ventilation include spontaneous breathing throughout the ventilatory cycle and an intermittent pressure release phase that results in a brief decrease in lung volume to assist ventilation. Recruitment begins at the lower inflection point and continues to the upper inflection point. Therefore, elevated baseline airway pressure during APRV may produce near complete recruitment, thus minimizing low volume lung injury from cyclic recruitment. Additionally, APRV is less likely to produce overinflation or high volume lung injury as airway pressures are lowered or released to accomplish ventilation. Other lung protective strategies include optimization of current modes of ventilation and alteration of ventilator strategies to prevent or reduce ventilator-associated lung injury. Current goals of ventilation include the following: avoiding extension of lung injury, minimizing oxygen toxicity by using mean airway pressure, recruiting alveoli by raising mean airway pressure by increasing PEEP and/or prolonging inspiration, minimizing peak airway pressure, preventing atelectasis, and using sedation and paralysis judiciously. Four commonly used terms include pressure high, or P high, pressure low, or P low, time high, or T high, and time low, T low. P high is the baseline airway pressure level and is the higher of the two airway pressure levels. P high, or the CPAP level, is also called the inflating pressure or the P1 pressure. P low is the airway pressure level resulting from the pressure release. Other authors may refer to P low as the PEEP level, the release pressure, or the P2 pressure. T high corresponds with the length of time for which the P high is maintained. T low is the length of time for which the P low is held, or for which the airway pressure is released. The mean airway pressure can be calculated as follows. P high times T high, and add that to the product of P low times T low divided by the sum of T high and T low. This is a very important concept in APRV. Some ventilators may compute this automatically, making manual calculation redundant. Somewhat confusing to the understanding of APRV have been the subsequent descriptions of mode of ventilation that appear very similar to it. Biphasic positive airway pressure, or BiPAP, differs from APRV only in the timing of the upper and lower pressure levels. In BiPAP, T high usually is shorter than T low. Intermittent mandatory pressure release ventilation, or IMPRV, another mode of ventilation similar to and sometimes confused with APRV, synchronizes the release event with the patient's spontaneous effort. All spontaneous breaths are pressure supported to overcome the resistance associated with breathing through the endotracheal tube and ventilator tubing. Synchronization does not occur with the raising of the airway pressure, only the release. Because the concept of dysynchrony in APRV has not been demonstrated clearly and has been stated not to be an issue, the necessity of intermittent mandatory pressure release ventilation is questionable. Intermittent CPAP is based on the principle of APRV, but is intended for patients undergoing general anesthesia. Continuous positive airway pressure is applied at a level that will provide an adequate tidal volume, then removed for 1 second to produce tidal ventilation, then reapplied. Unlike APRV, intermittent CPAP is not intended to restore normal functional residual capacity or improved oxygenation, and it can be discontinued abruptly. Bilevel ventilation is defined as augmented pressure ventilation that allows for unrestricted pressure-supported spontaneous breathing throughout the ventilatory cycle. Although similar to APRV, it incorporates the option of pressure support in the airway pressure waveform to augment spontaneous breathing. Airway pressure release ventilation was designed to oxygenate and augment ventilation for patients with acute lung injury, or ALI, or low compliance lung disease. Airway pressure release ventilation also has been used successfully with patients with airway disease. Similar to CPAP, APRV can unload inspiratory muscles and decrease the work of breathing associated with chronic obstructive pulmonary disease. Unlike PEEP, an expiratory flow resistor, which decreases expiratory flow, peak expiratory flow rates are increased during the release phase of APRV, improving expiratory flow limitation. During APRV, exhalation is not limited to the release phase, as it is permitted throughout the respiratory cycle. The main cause of hypoxemia associated with ALI are shunting due to alveolar collapse and reduction in functional residual capacity. Therefore, a primary goal of the treatment of ALI is recruitment of alveoli and prevention of de-recruitment. Sustained plateau pressure is used to promote alveolar recruitment while being maintained at an acceptable level. In addition, the number of respiratory cycles is minimized to prevent both the repetitive opening of alveoli and alveolar stretch that may result in lung injury. Patients in early phase ALI often do not have impaired respiratory muscle strength or inadequate respiratory drive. Frequently, CPAP alone is sufficient to restore lung volume and increase lung compliance. However, when assistance with ventilation is required, APRV can be used. Intermittent airway pressure release allows alveolar gas to be expelled via natural lung recoil. Maintaining a constant airway pressure may be advantageous for several reasons. Constant airway pressure facilitates alveolar recruitment, enhances diffusion of gases, allows alveolar units with slow time constants to fill, preventing overdistension of alveoli, and augments collateral ventilation. The pores of Kohn, located in the septa of the alveoli and open only during inspiration, were first believed to be responsible. However, two additional pathways were later credited with playing a role. The canals of Lambert connect terminal and respiratory bronchioles with adjacent peribronchial alveoli, and the channels of Martin connect respiratory bronchioles and serve to bypass the main pathway. In normal healthy lungs, collateral ventilation may barely occur at the functional residual capacity level. However, alternative pathways may be opened at a higher lung volume. The role of alternative pathways in healthy lungs is very limited, but in disease states may be important. Although collateral ventilation is typically lost in pulmonary edema, collateral pathways may be reopened and oxygenation improved by increasing functional residual capacity. Sustained airway pressure, rather than intermittent periods of airway pressure, is more beneficial in the edematous collapsed lung. Sustained breaths maintain a constant airway pressure and allow collateral channels to assist in producing ventilation. Collateral ventilation efficiency drops as respiratory frequency increases. Airway pressure release ventilation uses these concepts, maintaining sufficient airway pressure for an adequate duration to open collapsed alveoli, thus improving recruitment of alveoli and increasing oxygenation. In patients with severe acute respiratory failure, the use of APRV results in significantly lower peak airway pressure when compared with continuous positive pressure ventilation. Lower airway pressures are thought to be associated with a reduced risk of ventilator-associated lung injury, or VALI, or VALI. Further, APRV requires lower minute ventilation rather than continuous positive pressure ventilation, suggesting less dead space ventilation. Studies of patients with ALI have shown that APRV supports oxygenation and ventilation while producing lower peak airway pressure than volume assist controlled ventilation and intermittent mandatory ventilation. Studies of injured lungs suggest lower airway pressure, reduced dead space ventilation, and improved oxygenation and ventilation when compared with intermittent positive pressure ventilation. Airway pressure release ventilation recruits lung units by optimizing end inspiratory lung volume. Ideally, the end inspiratory pressure, which equates to P high or plateau pressure, should be kept beneath 35 centimeters of water pressure. This protective lung strategy has several positive effects. First, the preset pressure limit prevents or limits overdistension of alveoli and high volume lung injury. Second, APRV affects tidal ventilation by decreasing rather than increasing airway pressure. Decreasing lung volume for ventilation further limits airspace overdistension and the potential for high volume lung injury. Third, maintaining airway pressure optimizes recruitment and prevents or limits low volume lung injury by avoiding the repetitious opening of alveoli. Spontaneous ventilation has a positive effect on the venous thoracic pump mechanism. Suppressing spontaneous breathing during continuous positive pressure ventilation can compromise cardiac function by decreasing venous return, thus cardiac output. The main advantage of APRV is that it allows for spontaneous breathing to occur at any point in the respiratory cycle. Depending on the patient's need, spontaneous breathing may involve only exhalation, only inspiration, or both. The distribution of ventilation is significantly different when a spontaneous breath is compared with a mechanically controlled or assisted breath. Spontaneous breaths tend to improve ventilation perfusion matching by preferentially aerating well-perfused dependent lung regions. Mechanically delivered breaths primarily ventilate areas away from those receiving maximal blood flow. This phenomenon is consistent with earlier research, which demonstrated that spontaneous ventilation opens more alveoli, improves regional gas exchange, and reduces atelectasis. Decreased need for sedation use or neuromuscular blockade use with APRV and BiPAP has been reported. Judicious use of sedation and paralysis in the mechanically ventilated patient was recommended at the American European Consensus Conference on ARDS. Unintentional prolonged paralysis is now recognized as a complication of the long-term use of paralytics. In addition, a paralyzed diaphragm moves very differently with a positive pressure ventilation compared with an active contraction. The paralyzed diaphragm is displaced preferentially along the path of least resistance, that is, into the abdomen of the non-dependent regions. This displacement leads to favored ventilation of the non-dependent lung regions. All of this contributes to ventilation perfusion mismatch and possible overdistension of healthy alveoli, leading to further hypoxemia. Consistent with other pressure-targeted modes of ventilation, APRV is affected by changes in lung compliance and/or resistance. Clinicians need to identify the scenarios that affect lung volume and monitor patients for changes in their tidal volumes. Because APRV is time-cycled, synchrony with a patient's spontaneous respiration does not occur. If a release phase is not synchronous with the patient's effort, discomfort may result. However, because APRV has a dynamic pneumatic system, inspiration and exhalation are facilitated at any time. Dysynchrony with APRV has not been identified as a problem in the majority of the literature to date. As with any new technology, staff stress and subsequent increased risk to the patient may be noted with the implementation of APRV. Adequate and appropriate on-site training, coupled with off-site support services and backup, will help resolve some of the stress and decrease the risk associated with the introduction of APRV. Transferring patients to subacute areas as their disease processes improve may cause these issues to be revisited. Further, these areas may not have access to ventilators capable of delivering APRV, which will require switching the patient to a different mode of ventilation. Similarly, traveling to other departments, such as radiology, hyperbaric oxygenation chamber, may require temporary discontinuation of APRV, causing undue anxiety or discomfort in some patients. Little direction on the application of APRV can be found in the literature, other than as suggested by vendors and limited study protocols. However, based on an understanding of the pulmonary physiology and pathophysiology, coupled with the theoretical understanding of mechanical ventilation and current recommendations from consensus conferences, the following technique has evolved. When changing a patient's mode of ventilation to APRV, the initial settings are partly deduced from values of conventional ventilation. The clinician converts the plateau pressure of the conventional mode to P high and seeks an expired minute ventilation of 2 to 3 liters per minute, less than when on conventional ventilation. This is accomplished by setting P high at the plateau pressure with a ceiling level for the P high normally at 35 centimeters of water pressure. P low is set at 0 centimeters of water pressure. A P low of 0 produces minimal expiratory resistance, thus accelerating expiratory flow rates, facilitating rapid pressure drops. T high is set at a minimum of 4 seconds. A T high of less than 4 seconds begins to impact mean airway pressure negatively. When attempting to avoid alveolar overdistension, the clinician must be cognizant of the plateau pressure, as this is the best clinically available estimate of alveolar pressure. A plateau pressure, or P high greater than 35 centimeters of water pressure, is associated with lung injury and therefore should be kept beneath this level. Rarely, an elevated P high of 40 to 45 centimeters of water pressure may be indicated, especially for patients with low compliance respiratory systems, like individuals with morbid obesity, abdominal distension, or chest wall edema, either for the purpose of oxygenation or ventilation. Although not optimal, the increased P high would be less than the pressure generated by conventional modes to produce a similar response. A P low of 0 is selected because minimal resistance to exhalation is the goal. Higher pressures may impede expiratory gas flow during passive lung recoil. The valid concern of collapsing alveoli with a P low of 0 is negated with the use of a short T low, around 0.5 to 0.8 seconds, to maintain the end expiratory lung volume. The minimum T high duration is 4 seconds. The goal is to create a nearly continuous airway pressure level, which serves to recruit collapsed alveoli and maintain recruitment, thus optimizing oxygenation and compliance. As a patient's lung mechanics improve, T high is progressively lengthened to 12 to 15 seconds, usually in 0.5 to 2 second increments. A further advantage of the long T high is the reduction in the number of opening and closing of the small airways, one of the mechanisms implicated in the development of iatrogenic ALI. The T low is probably the most closely studied of the 4 parameters. Early writings suggested a T low of 1.5 seconds as the norm, which allows for complete emptying of the lungs. A longer T low, around 3 to 4 seconds, in animals with ALI was associated with a decrease in arterial oxygenation and the accumulation of hemorrhagic fluid in the endotracheal tube. An excessively long T low encourages alveolar derecruitment, atelectasis, and airway closure during the release phase. Alternatively, an insufficient T low potentially may result in inadequate exhalation, leading to dead space ventilation, hypercapnia, and hemodynamic compromise. Optimal release time allows for adequate ventilation while minimizing lung volume loss. Essentially, release time should impede complete exhalation in the slower compartments of the lung, such as the areas of high compliance or high resistance to exhalation, and generate regional intrinsic peak. Theoretically, this will enhance alveolar recruitment. Low compliance states, such as ARDS, will have lower or shorter expiratory time constants, and therefore a lower or shorter T low. High resistance diseases, such as asthma, will have longer time constants and require longer release times. Determining the correct multiple of time constants to calculate T low is a challenge of future research. In practice, however, the clinician does not calculate the time constants for each patient, but rather relies on an approximation of the restriction of expiratory flow, as indicated by the expiratory flow of gas waveform. When expiratory flow falls to approximately 25 to 50% of peak expiratory flow, the clinician stops the release time and allows the airway pressure to return to P high. The current technique of weaning from APRV is guided by general principles of weaning used in clinical practice today. Knowledge of the signs of respiratory failure, as well as exclusion or correction of contributing factors preventing successful weaning, such as excessive secretions, bronchospasm, sepsis, anxiety, and diameter of endotracheal tubes and other dead space devices are paramount. The approach in APRV is to maintain lung volume, improving both oxygenation and ventilation. As such, rarely does a specific point in time occur when weaning is officially commenced. Primarily, the method to reduce support is through manipulation of P high and T high. P high will be lowered 2 to 3 centimeters of water pressure at a time, and T high will be lengthened in 0.5 to 2.0 second increments, depending on patient tolerance. The goal is to arrive at straight CPAP, usually at 12 centimeters of water pressure, and then the clinician either weans CPAP or simply extubates the patient at 6 to 12 centimeters of water pressure. Before switching to CPAP, P high often is approximately 14 to 16 centimeters of water pressure, and T high is at 12 to 15 seconds. Patients with more severe forms of ALI or ARDS are weaned on a slower basis. Changes in mean airway pressure are monitored closely for their effect on oxygenation. Similarly, exhaled minute ventilation is tracked in conjunction with CO2 removal. Airway pressure release ventilation can maintain oxygenation and ventilation at a level comparable to continuous positive airway pressure. Airway pressure release ventilation is associated with significantly lower peak airway pressures and dead space ventilation. Airway pressure release ventilation uses almost constant airway pressure that not only facilitates alveolar recruitment, but also sustains that recruitment once it has occurred. Spontaneous, unsupported breathing during APRV may occur at any point in the ventilatory cycle. Spontaneous breathing is advantageous because it decreases intrapulmonary shunting and improves venous return. The ability to avoid neuromuscular blockade and decreased use of sedation have resulted in fewer complications and decreased drug costs. Finally, ventilator-associated lung injury, which can result from both high and low volume lung ventilation, may be balanced and averted. Few clinicians believe that any single isolated treatment can be responsible for a major improvement in the outcome of patients with ARDS. Combination therapy is expected to be the standard, including such concepts as prone positioning and permissive hypercapnia. Part of that therapy may include the ventilator strategy of APRV, which incorporates the advantages discussed. We believe that future research will support the use of APRV as the mode of choice for patients with ALI and ARDS.